As many of you may have known, in about 2008, the World Health Organization finally recognized surgery as maybe a component of primary health care. You'll see up on the outer side here, surgery, right here, is listed as a component of now public health according to the WHO. But so often the definition of what that is usually basic and emergency surgical care. Does it really incorporate all the aspects of surgical care as we know it today? And I think that what they look at was really expressed well by Dr. Mock. Dr. Mock is up in Seattle. He worked with the WHO for many years and has been very prolific in trying to promote surgery as a public health issue. And some of the things that make it a public health issue is finding those things that have a large public health burden or a large burden of disease. The treatment is highly successful, but it's also very cost effective. And some of these things we've heard from Jeff Tabin in cataract surgery, how that has become cost effective. There's groups teaching hernia, and there's information about how providing hernia care is cost effective when we compare it to other current public health initiatives. Paul Farmer wears a little badge on his lapel at the Brigham, I understand, that says CBA equals SFTP. Now, I can't tell you what SFTP really stands for because we don't speak like that here in Utah. So I've changed it a little bit, and it's cost-benefit analysis equals no surgery for the poor. So as you go down to Haiti, not just taking care of the victims down there, we run into people who just aren't getting the care that they need as you find the breast cancer or the other tumors that have no access to health care lying around that need to have care. Fiamu mentioned this article by Dr. Weiser that indicates that where resources are put in for surgical care, there's a lot of surgery. In those countries that spend more than $1,000 per person per healthcare per year, we'll have in those countries 11,000 procedures being done. But if you spend less than $100 per person, there's almost nothing. And so how do we adjust that in this worldwide? Well, there's Dr. Udwadia, who is a physician from India. And I think he is kind of a pioneer in laparoscopic surgery for the Middle Asian continent, specifically in India. Said that there were 3 revolutions that were patient-friendly. And these are aseptic technique, anesthesia, and endoscopic and laparoscopic surgery. These are things that have dramatically changed the ability to care for patients in the last 100 years. However, when we go into the developing world and we look for a laparoscopic cholecystectomy, we're usually finding the open cholecystectomy with a high rate of wound infection, people off work for a lot longer, as opposed to what we have here in the United States where we know all the benefits of laparoscopic surgery, faster back to work, less pain. And when you start thinking about how that might help build the economies in these countries, actually may be quite significant. Well, some people don't really realize that. Dr. Contini is a wonderful gentleman who I invited to come and teach with me in Hovd, Mongolia to teach laparoscopy. Of course, I hadn't realized that just before he came, he wrote an article on why we shouldn't be doing laparoscopy in the developing world. And he said, we have serious doubts that many Afghan people, because he was talking about Afghanistan, may really benefit from the advantages of laparoscopic surgery. Don't think they benefit from earlier discharge, or quicker recovery and return to work, or less pain, post-operative pain, or less scarring. Is that true? These people don't need that kind of help. In fact, there are other articles that indicate people in resource-poor areas may need this much more than other people. Well, how do we put something that, we all know laparoscopic equipment is quite expensive. So in trying to look at laparoscopic surgery as an example, and I'm not trying to promote laparoscopic surgery so much as using this as a case study for hopefully things that we can do in surgery throughout the world. And I think we have to look at the entire ecosystem as we look at what surgery can do. Because technology, I'm convinced that technology is the key, as we've heard other people today, in getting surgical care into these resource-poor areas. The appropriate education ties in with that technology we just heard. What about community involvement? Not just the community that the people live in, but the community of surgeons and nurses and pharmacists and different groups that are working within that same community. Or the healthcare models. Looking at the business models, I think, is an important aspect. And if we don't understand how we can put a business model into place to have laparoscopic surgery take place in some of these areas, it will not be sustainable. And then a multidisciplinary approach, an interdisciplinary working group of what we have put this conference together for is for bringing engineers, business people, public health, surgery, anthropologists, to identify the barriers of getting this type of surgical care into the resource-poor areas so we can begin to find solutions. So I am convinced, as an example, that laparoscopic surgery, in the words of Clayton Christensen, is a technological enabler for improved health care overall. Not just for getting laparoscopic surgery there, but can improve the health care in these communities. These are pictures of us teaching laparoscopic surgery in at least 3 of the rural hospitals, the regional diagnostic centers over in Mongolia. And I'd like to explore a little bit of what that has been doing in that country. Because I think as we look at laparoscopic surgery, in Mongolia, gallbladder disease is extremely prevalent. It's a targeted disease process. Laparoscopy has helped us build community trust so that we can go on and teach basic and emergency and essential surgical care. It has gone on to help develop professional development, but not only to make them better doctors, it gives them their own self-esteem, that they can provide for their people modern surgical care, just like the rest of the world that they see on the internet or learn on a cell phone. I mean, we just tweeted a few minutes ago. Does anybody know who was just named as probably the new director of the World Bank? Who in here is tweeting? Dr. Kim from Dartmouth. A wonderful position there. So, accessibility to surgical care. By building surgical care in regional centers and modern surgical care can provide access to an entire country. Improve surgical and medical care. Can teaching laparoscopy help even improve basic medical care? And we'll look at that real quickly. In Mongolia, Mongolia is the most sparsely populated country in the world. 49% of the population still lives a nomadic lifestyle. And trying to travel and get health care is very difficult because of these vast rural areas. So how do we do this in that kind of environment? Well, in about 1994, there were some really forward-thinking surgeons. And I want you to notice how many of these in this picture are American surgeons, just one. 3 of them are Mongolian surgeons. And I think this is one of the keys, is finding out what the local people want, what they need, and trying to figure out how we can help provide that is a key thing in making surgery sustainable. Dr. Buck Rusher was the impetus behind this. When he was in Mongolia, they asked him to help set up laparoscopic surgery. So they did the first laparoscopic surgery in 1994 after doing training both in the US and back in Mongolia, but it stayed at a very low rate. Only about 2% of the gallbladders were removed laparoscopically until 2005. It was at that time that I think one of the next key points that has been mentioned here is finding a key person to work with that you can trust. This key person is here in our audience, Dr. Segerlin. Dr. Segerlin came and said, when I went over there to teach trauma, because that's what I knew they needed, and nobody wanted to listen, she came over and said, would you please come to our university hospital? We want to show you what we had been doing in laparoscopy. And then she said, in our country, gallbladder disease is an extremely high cause for inpatient morbidity. And we need help. Our people need laparoscopy. They can't be out of work. They need to get back to work sooner. We can't afford the cost of having them in the hospital longer or the cost of the wound infections. And I actually was under the understanding at that point, you know, you're nuts, lady. There's just no way. This is crazy. And no, they don't need it here. But she really had a little PowerPoint presentation. And we came back home and said, what can we do about this? So together, we developed a course, and we brought over a multidisciplinary team The concept was to not just teach surgery, but to teach the entire system. To teach the surgeons, the anesthetists, the nurse, the scrub techs, the biotechnicians, and take a surgical resident along so we could show the University of Utah how beneficial this might be academically. So, we go over and start doing some of this work. We find out that there is a healthcare system, Dr. Segerlin showed this, where it's a tiered system. The primary care facilities, the regional hospitals, and the tertiary care facilities. Now, she tricked me because she said, come teach at the university. I said, that's great. We survived that one, and it went very well. But she said, next year I want you to come teach in one of our rural regional centers, Erdenet. That's when I thought, you're crazy. Again, there's just no way. But again, she said, no, our people need laparoscopic surgery. They need this benefit. So we sat down, and as we were doing last night for an hour, planning this year's trip, we planned what it is that she felt like we really needed to do. And we targeted the secondary medical care hospitals, the IMAG hospitals. These are the ones, she said, we need to take them to the 4 regional hospitals in our country that the government has targeted to build up with resources, both educational, physical, infrastructure. We need laparoscopy in these facilities so we can have access throughout our country. We agreed at that time to do this in a way where we would visit each facility at least twice. This year we'll complete the project, and not only those 4, but an additional one called Muran, where we will now have been to all these places twice to be able to teach laparoscopy. But everybody was asking, how can you just go over there and teach it? Aren't they going to hurt people? How are you going to sustain it? How are you going to sustain the equipment? And we initially began by taking equipment that was refurbished. Then we got together with industry because we thought the refurbished equipment was going to last very long. And we got a lot of support from Mrs. Stortz, who helped us take brand new equipment. Then the question was, well, how do we sustain this long term? So we brought in the representatives from some of the companies from Irkutsk and Moscow to come and teach with us in Mongolia, in these areas, to the point now that Mrs. Stortz has hired a Mongolian person to support the equipment that is in Mongolia. So it's forming now a business in Mongolia to support the surgery that we're building there. Now, this is an 8-year project that we've been working on. We found very interesting as we began to look at information about gallbladder disease in Mongolia. As you look at this graph, laparoscopic surgery, which has been at 2%, or very, very small numbers, is now starting to rise. Now, the percentage change may not have changed because open chole has actually doubled during this time. I asked this patient of ours, who actually is an internal medicine doctor, but she is making more money by teaching the local people a business class, why she thought we're seeing this effect in Mongolia. She said, well, it's very obvious. She says, you come over here and you teach our doctors modern surgery, and we see the patients coming out doing well, and they go back to work very quick. We now trust our doctors that when we go to the hospital, that we can leave the hospital alive. What are the cultural aspects? That's why we had anthropology come and talk to us. What are the cultural barriers that we have to trying to expand the surgery that we think is so beneficial? Now, we can't take credit. It's just laparoscopic surgery. Dr. Segerlin presented information about the program of the Global Initiative for Emergency and Essential Surgical Care that has been taught throughout the country. That was begun at about the same time. That was really targeting the SUM hospitals. I think there's a lot of things that are going at the same time to help improve surgical care. Well, developing surgery improves capabilities and support for general medical care. If we bring laparoscopic surgery in, all of a sudden we think we need to have more x-ray capability. Dr. Ganbat is actually Dr. Ayunbold's father. Dr. Ayunbold is here with me. Dr. Ganbat received the award for the best surgeon in Mongolia 2 years ago. He came to me about 5-6 years ago and said, we need laparoscopic surgery in our Eastern Regional Hospital. And we made a plan, we'd come in a few years, but he was impatient. So he went to the Dutch. and got a financial program that was able to bring in X-ray as well as the initial laparoscopic equipment that worked out well to help some of the other teams come in and begin laparoscopic surgery in their town. So when we came, it actually even worked much better. Here they have digital radiography that they had brought in just the year before we arrived. And the person on the table is a person who had a gallbladder surgery, open surgery, because they had a common bile duct stone, of which we thought we got out, but we didn't. But we were able to get the right X-ray now and go back and do a transduodenal sphincteroplasty, something that they don't do there. What about light sources? Many of these areas you can't see. You can see how we're doing a tongue laceration by sunlight. But by bringing laparoscopy, here we're doing a laparoscopic-assisted abdominal peritoneal resection in the capital. We need better light. And to be able to do things, we have to develop that capability as well. Blood banking capability. That poor lady we're doing that laparoscopic-assisted abdominal peritoneal resection, bled from a big pelvic vein. We held our finger on that for 2 hours while they ran around the Capitol to find enough blood for us that we could resuscitate her. That was 6 years ago. Blood banking, the picture I have here, is now in all the regional hospitals throughout the country. In the town of Treubelsen, we can see what's happened to surgery there over the last 3 years. Previously, no laparoscopic cholecystectomy. Now cholecystectomy is the primary way that they remove gallbladders. And again, laparoscopic or total cholecystectomies have doubled. The capability to do these things is improving. Now, not just for basic surgery. Dr. Hagwa, who we taught to laparoscopic colectomy, has gone on to become the medical director of a private hospital. We heard about private healthcare in Africa. Same things happens in Mongolia. And when I asked him, I said, well, should we really be teaching laparoscopic colectomy here? Are we going to be able to sustain it? The people on the ground say, cost is one of the difficulties for us. But if somebody will not use advanced technology in our countries, the patients have to go to another country. Then the cost will be much higher. It was FIMU that showed me the company in Nigeria that won the award for the best healthcare company. Was in 2009, 2010. And they got it because they advertise on the internet that they provide a different opportunity for Nigerians who don't have access to any good healthcare in Nigeria. They'll fly you to India. That's their best healthcare company. Laparoscopic adrenalectomy. When we were there, they asked us, could you please help us do a laparoscopic adrenalectomy? I said, I can't teach you how to do a laparoscopic adrenalectomy by doing just one. But this lady had Cushing's disease, and she had a unilateral tumor. I said, we will show you so we can show you what can be accomplished. But you can't just start doing this. You promise me. It was a year later when we showed up at the airport that the endocrinology surgeon showed up at midnight to greet me, all excited to say, Dr. Price, we just did our first laparoscopic adrenalectomy ourselves. My next question was, is she alive? He said, no, you don't understand. And I didn't. He said, you got us so excited that we found funds, and a couple of us went to Korea for 3 months, and we have learned how to do this as well. It's not only the level of income that a society that gives quality to the lives of its inhabitants. Rather, it is people's capabilities to lead the lives they value that matters. We need to understand what people want. So this is Mongolia. What about the rest of the world? When you look at what has been published about laparoscopic surgery and laparoscopic cholecystectomy specifically, the countries on the left are all things that have been published from these countries doing laparoscopic cholecystectomy. On the right are other countries where I know have either visited or talked with people and heard stories of how they are implementing laparoscopic surgery in these countries. When I was in Cuba speaking, I met with Dr. Kibatala and Dr. Makembe from Tanzania. They had a letter that they were sending to Mrs. Stortz. They'd already been up to Germany to view the factory there and gaining support to try to set up laparoscopic surgery in Dar es Salaam. They've gone to SAGES. And this year in August, SAGES is going to begin their first course in teaching laparoscopic surgery in Dar es Salaam. When I was in Cuba, the Cubans showed me their experience with transvaginal cholecystectomy using very resource-limited instruments and supplies. This is from FIEMU, and FIEMU, I think you're the one there doing the first chole in Nigeria. But FIEMU sent me this information. They did a survey through this company Trigen over in West Africa. And they asked the West African College of Surgeons, and correct me if I get this wrong, if they had an opportunity, or what were the most important skills they felt they needed. And I want you to see what is number one here. I know it's hard to see. It's endoscopic and laparoscopic skills. And then the next one is ultrasound skills. Basic and emergency surgical skills is way down on the list. If you can go in and teach laparoscopic surgery, you can also begin to understand all the other issues that are there, and you can implement basic and emergency surgical skills and sterile technique courses and other things. In Afghanistan, where Dr. Contini was referring, what happened there? Look what happened to the numbers in overall gallbladders. 4 times what was being done previously when they instituted laparoscopic cholecystectomy. Greece, a lot of these places, just like Mongolia, takes time. Laparoscopic cholecystectomy started much earlier. But eventually, either with business models, healthcare models, re-engineering the equipment, I'm not sure what it is in Greece. There's an opportunity to be able to change. What is the interest in China? I went over with SAGES. We'd sent over a team ahead of time. It was all planned out. We were going to go teach 2 surgeons laparoscopic surgery. And when we arrived, we found banners across the front of the hospital, down the sides, across the streets, welcome SAGES experts, and they invited people and surgeons from 16 different hospitals to come to our week-long course. Now, Shanghai does better laparoscopic surgery than we probably do in Salt Lake City. They do a lot of solid organ laparoscopic surgery, robotic surgery, but when you get into the central areas of these places, it doesn't exist. And we went and visited some of these hospitals, these 16 hospitals, all very capable, or many of them very capable. There is a market. When you start talking about business, what is the market for laparoscopic surgery in the world? In Africa, in China. Dr. Langell spoke yesterday about the innovation of trying to design an inexpensive laparoscopic system. If we would have that, this laparoscopic surgery would revolutionize surgery worldwide, not just in developed countries. And like Dr. Udwadi has said, there really are 3 major patient-friendly revolutions. I would have us, people said, well, can you get us the story? Yun Bayar is a 22-year-old lady. With permission, we were able to go out to her home. This is her 4 days post-op from a lap chole. We wanted to find out how she lived and how this affected her life. She gets up at 6 in the morning to milk her horses. She milks her goats and her sheep. She goes out and gets the 40 liters of water from the well. She takes care of her 2 children. She's a shepherd's wife. She makes the cheese. She makes the milk tea. She does so much of what helps that society survive. She said, if I had to have that open surgery, I would just keep having pain and I'd be sick and lie down. I just couldn't have that open surgery. This laparoscopic surgery is so important to me to be able to get back to work, to my family. The information access is causing people to learn about this worldwide. I like pointing this out. Look at the gear, the yurt here. I hope you see the solar panel and the satellite dish, and you don't see the TV that's on the inside that's running by the solar panel. The information access is worldwide, whether or not it's through satellite or through cell phone. And I think this increases the participation of these global communities in trying to decide what they want and how we can try to find it. Laparoscopic surgery for gallbladder disease and gynecologic disease is likely to enter the realm of essential surgical services as the developing world inevitably develops cost-effective delivery methods. that cost-effective delivery method, not just the equipment, but the system, the healthcare system, the whole ecosystem is what we need to evaluate. Dr. Leslie Akapori said, as we now live in a global society, it would be unconscionable for Nigerians to be denied the medical advantages of new technology. In closing, I truly believe, as an example, that laparoscopic surgery has a huge advantage to this global ecosystem. But I think there's other areas of surgery that have the same effect. Now, what are these? Again, surgeons and community gain increased self-respect. They're able to maintain the expertise in the country. We have set up laparoscopic surgery in a way that it's in the regional diagnostic centers. In many areas, people say if you go teach them laparoscopy, they're going to leave and they'll go to a foreign country. Or they'll migrate to the capital, and that certainly does happen. But is there a method that we can put into place, like was mentioned with the PAC system, where you can encourage people to go to a rural area, to maintain them in that area? And I think if you put laparoscopic surgery out in the rural area where they can do good surgery, you can keep them there. Source for improved economy and poverty reduction. We're currently working on trying to figure out microeconomic businesses to help support the equipment and supplies for laparoscopic surgery. Promotes overall health care and improvement. Actually, back to the economy, just getting people back to work is so important. Promotes overall health care improvements, whether or not it's the basic infrastructure, blood banking, medical care. You can teach so much more when you're teaching them what they want to hear. And it's an impetus for technological advances that we need to continue to design so we can make surgery cost affordable for the 4 billion people that don't have access to it right now. Thank you very much.